We appreciate you joining us this morning. Before we introduce our speaker, there are some housekeeping items. We are broadcasting live via live stream in YouTube. So please use your microphones to ask questions so everybody can hear. The recording will remain available for viewing. Consider subscribing to our YouTube channel to get notifications when videos and presentations are added. For our viewers, if you would like to submit a question, please text DeBakey to 37607. You may also submit your questions via the live stream chat. We will be checking on those through the duration of the presentation. We have two conferences coming up in June. One is the pre-intern training for vascular residents, and this is on June 5 to 7th. And then we have cardiology for the non-cardiologists on June 17th. Well, without further ado, I'm going to introduce the speaker for today. Dr. Stephen Sanders is a professor of pediatrics at Harvard Medical School. He also serves as the director of the cardiac registry at Boston Children's Hospital. Dr. Sanders attended Georgetown University, and he received a Bachelor of Science degree. He received his medical degree from the University of Louisville Health Sciences Center. He completed pediatric residency at the University of Oregon and pediatric cardiology fellowship at Boston Children's Hospital. He was the director of the cardiac non-invasive laboratory at Boston Children's from 1983 until 1994. And he became the chief of the Division of Pediatric Cardiology at Duke University for 7 years, and he subsequently became the chair of pediatric cardiology and cardiac surgery at Bambino Gesù Hospital in Rome, Italy. In 2010, he returned to the US and he became the director for the cardiac registry at the Boston Children's Hospital. This is a collection of 4,000 catalog heart specimens. His primary interests include the embryology and morphology of congenital heart defects and anatomy, imaging, correlation. This comes from the times where the anatomic correlation was the rule to understand echocardiography. Dr. Sanders is a pioneer in congenital echocardiography and a master in complex congenital anatomy. He is a world-class, devoted educator with unparalleled passion for the field. He has trained many generations of congenital cardiologists and continues to welcome cardiology and cardiac surgery fellows from all over the world to learn from him. Dr. Sanders is a trusted mentor and advisor to some of the most remarkable pediatric and adult congenital cardiologists. He will be leading a congenital workshop for over 40 fellows from the Houston areas tomorrow. Dr. Sanders, we're thrilled to welcome you to Houston. The stage is all yours.
Thank you, Dr. Duarte. Thank you very much, and thank Jennifer Collins for all of her help in getting this all organized. We really appreciate it. It's very nice to be back in Houston. It's been some years since I've been here, but I hope the weather improves from what it looks like today. So I have no disclosures to make. In 1971, Fontaine and Baudet introduced a new operation for tricuspid atresia. And a couple of years later, in 1973, Dr. Billy Kreutzer in Buenos Aires introduced a very similar operation. Their work, at least initially, was independent. Dr. Kreutzer knew about Dr. Fontaine's work before he published, but not when he started. So these were really independent introductions of unprecedented at that point operations in humans to redirect the systemic venous blood directly into the pulmonary arteries. And this was a pretty bold move for a couple of cardiac surgeons to make, and it's important to understand the basis for their belief that this actually would work. And there really is quite a large body of work before this, examining the need for a right ventricle in the circulation at all. This goes back to really the mid-1940s with Isaac Starr and his colleagues at Philadelphia, where they used electrocautery to destroy the anterior wall of the right ventricle to basically see what would happen. And what they say is that there was absence of conspicuous increments of venous pressure even after severe damage of the right ventricle. In fact, the pulmonary waveform looked pretty much the same. The dogs were fully saturated, had normal blood pressure, and apparently normal cardiac output after this. Some other groups did similar work a little bit later, using the same kind of technology or injecting gel into the right coronary in dogs to destroy the right ventricle, and again showing very little effect on the dog's hemodynamics. So the idea of the dispensable right ventricle became in vogue at that point. This was sort of in response to the controversy at the time of whether there really was such a thing as right heart failure. This was a major controversy then, or whether all heart failure was really due to left ventricular problems. So this led some other groups, Rothbard and Wagner, particularly at Michael Reese Hospital in Chicago, to propose that the pulmonary arterial pressure was found to be low on the order of 25 to 10 in virtually all the animals that had been studied, including humans. And considering those data suggested that the visa tergo for pumping the venous blood through the lungs might be supplied adequately by venous pressure. And so this concept was then explored by some groups, partial right heart bypass. The first one really was a group at the University of Padua in Italy, the Carlin and Mondini and DeMarchi, did an operation in dogs where they took the stump of the azygous vein and connected it to the right pulmonary artery and ligated the cavo-atrial junction. So this is what we today would call a Glenn operation, a classical Glenn operation, or a superior caval right pulmonary artery anastomosis. After a few technical problems that they solved early on, the dogs actually survived, at least in the short term that they allowed them to survive, were fully saturated, had a normal blood pressure. The caval pressure was a little bit elevated, but not much. It was in the low teens, millimeters of mercury. The reason that they had explored this was because they were unhappy with the Blalock-Taussig shunt that was in vogue at that time, or the Potts shunt. They thought this would be better because it was easier to construct. These were larger vessels than a very small child's subclavian artery. And this was venous, systemic venous blood going into the lungs, much more efficient than putting partially arterialized blood into the lungs. And they thought that this would protect the lungs from the possibility of pulmonary hypertension, pulmonary vascular disease. Of course, we know the work of Dr. William Glenn and his fellow Jose Patiño, who did the same operation, a superior caval to right pulmonary artery anastomosis in dogs, and were able to get good long-term survival with this, with again, modest increases in systemic or in the superior vena cava pressure and fully saturated dogs who seemed to act normally. And this was a couple of years later after Carlin, who'd actually done the work in 1949, published it in Italian in 1950 and then in English in 1951. Glenn apparently didn't know about Carlin. He doesn't reference it in his paper. And then a couple of years later in Budapest, Frank Robichek and his colleagues did the same operation, again apparently independently. So we have three nice examples here of documentation that in fact the systemic venous pressure can drive at least part of the systemic venous return through the lungs at a modest elevation in superior vena cava pressure. Glenn then used this idea and did the first superior caval right pulmonary artery anastomoses in humans. He reported this in 1958. This was the first case. This was his little surgical diagram over here of taking the SVC, putting it to the RPA, and ligating the cavo-atrial junction. And this was an angiogram in the first patient that he performed this operation. And this patient, at least according to Dr. Glenn, and he published a letter to the editor that we'll look at later in 1997, telling us that this patient was actually still alive and doing well with just a Glenn anastomosis. So this is an example of a Glenn anastomosis. We're looking at the heart and lung specimen from the front. And if we turn this a little bit to the right side here, there's the superior vena cava, the right superior vena cava coming down. And this would be its usual course down into the right atrium. But you can see there's a surgical clip right there that's been used to obstruct the cavoatrial junction. The anastomosis between the right pulmonary artery and the superior vena cava is there. This is the RPA, the right pulmonary artery here, superior vena cava on the other side there. And again, this would have been its usual course into the right atrium, but if we look in the right atrium here, you can see that the cavoatrial junction has been occluded. There's a sort of crimping of the tissue here by the clip, the surgical clip that's been placed on the base of the superior vena cava. And so now flow can come down the superior vena cava and go directly into the right pulmonary artery. So this is a classical Glenn operation. Now, a few years later, that was in '58 when Dr. William Glenn reported that. In '64, Haller and the group at Johns Hopkins University did a little modification of this. This is the first that I know of what we now call a bidirectional Glenn anastomosis. Bidirectional in the sense that flow from the cava can go into both lungs, both pulmonary arteries. So Haller reported this. They did an end-to-side anastomosis here into the right and didn't divide the right pulmonary artery as Glenn had done. They thought this was better because it allowed for better distribution of blood flow to both lungs, didn't distort the pulmonary arteries in any way, and so they introduced at that point the bidirectional Glenn. And this was in humans. These were patients with tricuspid atresia. You can see the diagram here is left ventricle, little right ventricular chamber here under the pulmonary artery. A very small VSD. Most of these patients had very little antegrade flow. That's why they were getting the shunt in the first place, because they were quite blue. So that was the introduction of a bidirectional Glenn. Now, it turns out that in 1997, this is what I was referring to before, Dr. Glenn published a letter to the editor pointing out that, in fact, they had done, he and Dr. Patino had done this kind of bidirectional Glenn anastomosis, the superior vena cava going to the pulmonary trunk here, or the pulmonary bifurcation, but they only did it as a temporary measure, so they didn't have to initially divide the right pulmonary artery. Then they did other experiments where they tried to connect the right pulmonary artery to the IVC. That didn't work out so well. So they only used this temporarily, and they never explored it clinically, never really published it until this publication in a letter to the editor in 1997. But this was a page from Dr. Patino's laboratory notebook where he drew all the operations that he and Dr. Glenn had done, and you can see the diagrams here indicating that, in fact, even in the early 50s, they had actually invented a bidirectional Glenn, but then never really did anything with it. So now that we have evidence that you can use the systemic venous pressure to drive blood through the pulmonary vasculature, the idea of the right atrium as a pump really dates back to William Harvey in his tract De Motu Cordis from 1628, when he described the circulation of the blood. He said, in some men of sturdier frame and stouter make, the right auricle is so strong and so curiously constructed within of bands and variously interlacing fibers that it seems to equal the ventricle of the heart in other subjects, suggesting that it might actually serve as a pump. In the group at Minnesota, this was in the mid-50s in Minnesota, really a lot was happening there in cardiac surgery. There were basically two teams of cardiovascular surgeons. Dr. Richard Varco was the head of one team, and of course Dr. Seawalt and Lillehei was the head of the other team. And Dr. Varco's group began to explore the idea of the right atrium as a pump. They wrote that the current progress in the management of congenital heart disease is not sustained in the case of patients with congenital tricuspid disease, like tricuspid atresia, or pulmonary stenosis also. And the preferable goal would seem to be application of a direct pumping mechanism to force venous blood through the pulmonary circuit. So they did some experiments in dogs where they connected the right atrial appendage to the side of the pulmonary trunk and then obstructed the tricuspid valve, oversewed it, ligated it. They found that if they did that acutely, the dogs didn't survive, but if they created tricuspid stenosis first by partially closing the tricuspid valve and letting the dogs recover for a few weeks and then creating the atriopulmonary anastomosis and finishing closing the tricuspid valve, that they did survive and that they did all right. The systemic venous pressure went up to mid-teens, 15, 17 millimeters of mercury, but they were fully saturated. Some of them had serous drainage, but most of the dogs, they got medium-term survivors out of this. Now, Haller's group, again, the group at Hopkins, using a little bit modification of the bidirectional Glenn anastomosis as the connection, did a similar thing. They closed the tricuspid valve, but instead of connecting the atrial appendage to the pulmonary artery, they did a side-to-side anastomosis between the superior vena cava and the right pulmonary artery. And this was also successful. They had some long-term survivors with this. Again, some of them had drainage, most of them didn't. Most of the dogs seemed relatively normal with normal blood pressure and normal saturations. And when they did autopsies in some of their survivors, they found that the right ventricle had really largely atrophied and was quite small. So all of this work indicating that the right atrium could actually function as a pump led Fontaine and Baudet, I think, to their ultimate use of it in the Fontaine operation that we are familiar with. So they said, we were of the opinion that the right atrium of a normal heart could not provide the required work, whereas a hypertrophied right atrium, as in tricuspid atresia, could supply the additional work represented by a pulmonary arterial pressure higher than left atrial pressure. And that led to the Fontaine operation. This was the original Fontaine that was described in 1971. Basically what they did was create a superior cable right pulmonary artery anastomosis, a Glenn anastomosis, and then used a valved conduit between the right atrium and the left pulmonary artery, closing the atrial septal defect. And initially they put a valve in the inferior vena cava, but Dr. Fontaine stopped doing that after the first few cases because it was clear this was causing more trouble than it was worth. It was becoming obstructed and not worth putting it in. Dr. Kreutzer's operation, initially he did one somewhat like this using a valved conduit, but it was a homograft actually, a radiation-preserved homograft, and it scarred down and thrombosed, and the first patient that he did died, and then he changed the technique to just excising the pulmonary root and pulmonary valve and moving it over to the atrial appendage, putting a rigid ring around the annulus of the pulmonary valve and anastomosing that to the right atrial appendage. So these were the first types of Fontaine operations that were done. And this is a specimen that is very much like the Fontaine operation that Dr. Fontaine actually described. So here we're looking at the heart from the front again. This is, of course, the ascending aorta. And this patient had tricuspid atresia with transposition. You can see the aorta here is aligned with this anterior outlet chamber, large interventricular communication here, no tricuspid valve. Here's the left ventricle. You can see the smooth septum. This is the outflow foramen to the outflow chamber here in the aorta. It's quite large in this patient. This is the pulmonary outflow, quite stenotic in this case. This infundibular septum is here. And again, the outflow and the pulmonary outflow there in the mitral valve, mitral pulmonary fibrous continuity. So the conduit here is a Dacron corrugated conduit that you can see here. This has all been opened at postmortem, of course. And the conduit was connected to the right atrium. You can see the opening down into the right atrium here. And there's the ring of the bioprosthetic valve. This is a Hancock type of conduit with a bioprosthetic valve in it, and then the distal part of the conduit there. Here's the junction with the right atrium. You can see the right atrium here with the atrial appendage. There's the opening at the base of the appendage up into the conduit. And the patch on the atrial septum here, the atrial septal defect closure. So the inferior vena cava came in here, superior vena cava entered the atrium here. And so blood from the superior cava there and the inferior cava would run into the conduit through the orifice here in the anterior atrial wall, through the conduit, across the valve, and into the pulmonary arteries here in the back. So this is the right pulmonary artery. So if we turn this around from the back and look at it into the pulmonary arteries here, you can see the ostium of the conduit into the pulmonary arteries. This is the old pulmonary trunk that's been occluded at the time of the Fontan. And this is the right pulmonary artery here going out to the right lung. Remember, we're looking from the back, so that's right. And this is left, so this is the left pulmonary artery going off to the left lung. So that was sort of the original kind of Fontan. In the mid to late 70s, I guess, there was the first real modification of the Fontan came along. Marc de Laval at Great Ormond Street and other people, Dr. Castaneda at Children's and a number of other groups, instead of putting the conduit from the right atrium to the pulmonary artery, instead tried to incorporate the subpulmonary chamber into the Fontan circuit. And so the conduit was placed to the right ventricular outflow tract here. Catherine Bull, who was working at Great Ormond Street at this time, did some hemodynamic studies in patients who had had that kind of operation. And what she found in most of them was that the pulmonary artery pressure was really no greater than the right atrial pressure. It was the same or lower. So this was not really adding much. But she found a couple of patients where, in fact, there was almost a ventricular pressure tracing in this little chamber. And the pulmonary artery pressure was clearly above right atrial pressure. So it was doing some, at least, pressure work here. When they did stroke work calculations, this was the left ventricular stroke work, which looks really quite normal. But when they tried to calculate right ventricular stroke work, you can see that it was essentially zero in most of the patients. And in a few of them, it was actually negative. This subpulmonary chamber was actually an energy sink. It was making the whole circuit less efficient. And so this led to abandonment of this approach probably in the early 80s, I would say. We were still doing this by probably 83 at Children's, but I think after that point, everybody stopped doing that, and we certainly went back to an atrial-pulmonary kind of anastomosis. So this is an example like that. So this is a valved conduit from right atrium to right ventricular outflow tract in a patient with a fairly large subpulmonary chamber. So there's aorta, here's the pulmonary arteries, normally related great arteries. The aorta is to the posterior and to the right, the PA is here anterior and to the left. This is our left ventricle, which is a bit dilated in this patient. And you can see the aortic valve here, again, normally related great arteries. And this is the subpulmonary chamber, which is quite a bit bigger than a lot of patients with tricuspid atresia. And these were the ones where this was applicable. This is where the VSD was closed so that this no longer communicated with the left ventricle. And so flow from this chamber would then go out through the native pulmonary valve, which you can see here, and into the pulmonary arteries. And in most patients with tricuspid atresia, the pulmonary trunk is maybe mildly small, but it's often pretty normal, and the pulmonary valve is often pretty normal. So this kind of thing seemed appealing at the time. And so here you can see the branch pulmonary arteries, the right pulmonary artery here, and the left pulmonary artery there. And the conduit you can see here in the front, it was right in front, right under the sternum, and sometimes got flattened by the sternum. Here's our right atrium. Again, you see an atrial septal defect patch there. There's no tricuspid valve here in the floor of this right atrium, as you can see. And the orifice into the conduit is right there. You can see there's the opening up into the conduit. And here's again, a corrugated Dacron conduit. And there's a bioprosthetic valve in it. These valves ended up being a real problem. They almost never closed completely. Here's the subpulmonary chamber, and there's the connection into the subpulmonary chamber that you can see there. So that's that kind of Fontan. Now, this is a 3D reconstruction of a patient, living patient, with this kind of Fontan arrangement. And so we can look at it a little bit. This patient had had a classical Glenn anastomosis. You can see this is superior vena cava into the right pulmonary artery. And the atrial, cavo-atrial junction was reopened in the cath lab with a wire and stent to allow some of the hepatic venous blood to actually get to this lung, thinking that that might help with atrioventricular malformations, that, arteriovenous malformations that could occur there. And here's the conduit. You can see it's kind of long, and it comes over to this right ventricular outflow tract. There's a little subpulmonary chamber here, and then the pulmonary artery going off to the left lung. This is a little different arrangement. This is the same kind of operation. This patient had a sternal wire that caused a big artifact here. This was not really narrowed. This was the conduit from right atrium to the right ventricular outflow tract. You can see this is one of those patients that Catherine Bull probably found ventricular pressure tracing in. There's a much larger right ventricle here, or subpulmonary chamber. The atrium is quite dilated. You can see SVC here, IVC here. This patient had a left cava to coronary sinus. You can see this huge coronary sinus here in the back, and then the branch pulmonary arteries out here. So that's what that kind of operation tended to look like. Then, as I say, we and most people went back to doing an atrial pulmonary kind of operation, but without valves, with a non-valved conduit at this point, or a direct connection. This is a patient who had a RIP, a direct connection. This patient also had normally related great arteries and tricuspid atresia. So you can see this is the aorta here in the front. This is where the pulmonary trunk used to be over here, the aorta here. And there's a very small subpulmonary chamber in this patient, much smaller than what we saw in the last one. A little ventricular septal defect there. And here's our right atrium. Left ventricle is over here. It's a bit hypertrophied. You can see the walls are a bit thick. There's the aortic valve there. Aortic mitral fibrous continuity. And if we look in the right atrium again, you can see the patch again on the atrial septal defect here. And this patient has a very large coronary sinus because, like the last 3D reconstruction I showed you, this patient had a persistent left cava to coronary sinus, which is relatively common in tricuspid atresia. Here's the superior cava coming into the right atrium, inferior cava here coming in. So they drain back into the right atrium. And then this is the pulmonary trunk that was taken off from its usual location over here and moved behind the aorta and to the right and attached to the right atrial appendage. And this is the left pulmonary artery here, the bifurcation, the right pulmonary artery, and there's the bifurcation there in the middle. And you can see down here at the base, you can see that's the pulmonary trunk, the distal part, and there's the anastomosis with the right atrium there. So that is this kind of Fontan. This is a patient who had supra-inferior ventricles with a very small right ventricle up here, a big inferior left ventricle. The aorta here, this was the old pulmonary trunk, and it's been transected and moved over here to the pulmonary artery, superior vena cava, inferior vena cava in this patient. Let me just show you one little thing here. If we make this transparent, you can look in and see the left AV orifice here coming into this ventricle. And notice that there is a little orifice here also. This patient had a tiny tricuspid valve coming into this right atrium and was blue after, because nobody recognized this before surgery, and the patient was blue after surgery and eventually had this closed with a device. But you can see that funny things can happen. So the idea of staging the Fontan, not doing it all in one fell swoop, really came about because of data being presented in the early 80s. The group at St. Louis University, Pennington, and then the group at Chicago, at Children's Hospital in Chicago, Children's Memorial, Dr. Farouk Idris and Michel Lubawe's group there. Both of these groups reported that in their experience, it wasn't any kind of controlled trial, this was just a retrospective observation, that patients who had had a classical Glenn operation before their Fontan did better. Their survival was better, they had less serous drainage, shorter hospital stays, and so once this came out, people began to look into this idea. And the group at Duke reported their results with bidirectional Glens at this point. This was 1985. They had been doing bidirectional Glens for several years and had about 20 cases that they reported here. And what they found was that if they had done the bidirectional Glen prior to undertaking the Fontan, which was the case in about a dozen of their patients, they had 0 mortality. Whereas in the ones that they did it concomitant with the Fontan, there were about 8 or 9 of those, 3 of them died, so 30% mortality. And so they, again, reported improved survival, and I think that was certainly our experience, particularly working with patients with hypoplastic left heart syndrome in the late 80s and early 90s, that imposing another stage, a bidirectional Glen stage in between, we thought improved our results quite a bit. Now, why would that be? Well, I think we have to look at acute Fontan physiology to try to understand this a bit. These are data from Mark Gavelig from Leuven when he was working at Great Ormond Street. And they had a cohort of patients that were being followed there that he did echocardiograms on while they were in a palliated state, mostly with shunts. And then during the observation period, they underwent a Fontan operation. He did repeated echocardiography in the same patients. This was within about 48 hours of the Fontan. And then again, 2 years later in follow-up. And what you see, this is left ventricular dimension, but in these left ventricles, that correlates very well with left ventricular volume. And so what he saw was a marked decrease from about 140% of normal down to about 100% of normal left ventricular volume, which is a pretty dramatic change to happen overnight. And of course, along with that, one would anticipate a very marked increase in wall thickness because the myocardium doesn't just magically melt away overnight. And that's exactly what he saw. Whether he normalized it for body size or for heart size, you see a dramatic increase in wall thickness. And so when you go from a heart that looks like this to one that looks like this, what does that imply? Well, the radius of curvature drops pretty dramatically. The wall thickness goes up, as we said. If you think about what distends a ventricle like this, it's the wall stress acting on any unit volume, or if you want to think of it that way, on an individual myofiber. And that's a function of pressure, which probably didn't change very much here, maybe decreased even a little bit. Radius of curvature, which is in the numerator here, and it decreased, and wall thickness in the denominator, which increased. So wall stress, or the distending force for any given pressure inside the cavity, is much less under these circumstances than it is here. So it's very hard to fill this ventricle. Now, what do we have after a Fontan? Well, the only blood coming back to distend that ventricle is coming from the pulmonary veins. It has to cross the pulmonary vascular bed, and that's being driven by cable pressure, by systemic venous pressure. Patients come back, they may have a pressure in the SVC or IVC of 15, 16, 17 millimeters of mercury. Their left atrial pressure, we used to leave left atrial lines in, would be 7, 8, something like that. And very often, if you were around in the 70s and 80s as I was and took care of these patients, you remember patients who would come back from the operating room, have a systemic venous saturation of 40, 38, stop making urine after an hour or so, start to develop a lactic acidosis, start to become tachycardic. You could push volume, push the systemic venous pressure up into the low 20s. That's about as high as you can get it in small children, because then they start to transudate and develop edema. And that didn't push much more blood across the pulmonary arteries. And you couldn't really raise their left atrial pressure very much under this circumstance. And so they would tend to just spiral down and either die or go back to the operating room and get the Fontan taken down. But the situation's very different after a bidirectional Glen. you have the cava, inferior vena cava, still attached, still feeding this ventricle. So if you increase the systemic venous pressure here, you can recruit preload for this ventricle and begin to use the Starling mechanism to increase cardiac output. And that I think is why this made a difference in survival of a lot of these patients. Because then what happens, if you look again at Mark's data, if you look later at the wall thickness, it goes away. These ventricles remodel. They lose a lot of this extra wall thickness. So if there's some time between the bidirectional Glenn and the Fontan, they're much more favorable candidates, much easier to fill their ventricle under these circumstances. So I think that probably is one of the major mechanisms for the staging of the Fontan operation to make a difference in outcome, particularly for candidates who are a little bit marginal. Then there were a whole other groups of congenital heart defects to which the Fontan circulation could be applied, but not quite as straightforwardly as tricuspid atresia. You couldn't just close the ASD in somebody with a double inlet ventricle, for example, because you got another AV valve here to deal with. So what do you do about that? Well, Professor Sir Magdi Yaqub and the folks at the Mayo Clinic, Dr. Gordon Danielson, Dr. Dwight Magoon, figured out that you could just patch close this AV valve and then still do an atriopulmonary type of Fontan, and that was done in a number of patients. This is an example of a patient like that with RAPA conduit after right AV valve occlusion. So this was a big double inlet right ventricle, an unusual kind of double inlet. Most are double inlet lefts, but this is a double inlet right. You'll see if we look inside here, this is a right ventricle. There's no wall that we would call a typical left ventricular septal wall. It's a bit hypertrophied. You can see here's the right AV valve here. The left AV valve is here, both coming into the same ventricular chamber, and here's the aorta arising from it. These are double inlets, double outlets by and large. And you can see there's the pulmonary trunk back there, posterior and to the left. It's quite stenotic and was eventually occluded at the time of the Fontan. There's a very dilated right atrium that you can see here. It's really huge. This patient survived for some time with the Fontan. There's the inferior vena cava. The superior vena cava is here. And this is the patch on the right AV valve. And you can see it's a big patch. It's been sewn in here to occlude the right AV valve. Now, this is prosthetic material, and what does prosthetic material do in the heart? It calcifies. And this is just like a rock. I wish you could hear the audio, but and on the inside, if we look from the right ventricle, you can see here's the same right AV valve. That's the one that's been occluded. So now the left AV valve, the other one, is what's draining the left atrium into this double inlet ventricle. So here's a living patient, or actually was until recently, with this kind of Fontan. This is a double inlet left ventricle. This is a big left ventricle down here, outlet chamber up here with the aorta. Here's a very dilated right atrium, superior vena cava, inferior vena cava, and you can see the branch pulmonary arteries here. It's an atriopulmonary type of Fontan, but if we again look inside the left ventricle here, you can see the left AV orifice over here, and here's the right AV orifice, and we've segmented this to show calcium density. This is the calcium in the patch on the right atrioventricular orifice that you can see here. And that's looking up toward the outflow chamber up here under the aorta. That's the communication between the left ventricle and this outlet chamber. So that's what these kind of patch closures of this look like. Now there's another way to do this, and that is just to migrate the atrial septum over here to the right of the right atrioventricular valve. And of course, Sir Magdi figured this out and reported this in the same paper in 1976. Part of his patients, he occluded a valve. Others, he did this, particularly if there was something wrong with the left AV valve. You want to use the right AV valve, you move the atrial septum over like this, and then do an atriopulmonary connection. And here's a patient who had that done. This is a double inlet left ventricle, but an unusual type. This is with normally related great arteries, what we call a Holmes heart. So here's the aorta, which is posterior and to the right. The old pulmonary artery was up anterior and to the left, just as you would expect. This patient obviously had a pacemaker here. And looking inside the left ventricle, this is clearly a left ventricle with the septal wall here. You can see this big right AV valve here. And look at the left AV valve. You wouldn't want to use that as your AV valve. It's a very small stenotic left AV valve. This is the outflow foramen up to the what was the pulmonary trunk, and the aorta. The aortic outflow is in there between the two AV valves. So here's our outflow chamber right here. You can see it's pretty good size. There's a big interventricular communication there. And then this is the old remnant of the pulmonary valve. This was destroyed at the time of Fontan operation. The pulmonary trunk was divided and oversewn here. So this is all used to be the pulmonary valve coming from this outlet chamber, typical normally related great arteries. Now let's look back at the atrium. Here's our right atrium. And there's a big Dacron patch that you see has been put in here. You can see it's been anchored over here near the right atrial free wall to the right of the right atrioventricular valve. So it's sewn in here to segregate off this part of the right atrium here that's going to receive the inferior vena cava from here and the superior vena cava from above on this side of the patch. And on the other side of the patch is where the atrioventricular valves are. So that big right AV valve is on the other side of this patch, just there. And then the right atrium was then connected to the pulmonary trunk, which is here, which was removed from its usual location and brought over to the right side. So there you see the pulmonary trunk connected. So this is an atriopulmonary type of arrangement. And now if we just look at this for a second, you begin to see how this is starting to look like a lateral tunnel. And in fact, that may have been why the lateral tunnel came about. Probably Marc de Laval was one of the ones who was instrumental in popularizing this. Certainly we used this, Dr. Castaneda, Dr. Norwood at Children's Hospital used this technique as well, using sort of a half of a Gore-Tex tube here to create a wall within the right atrium. The back wall was atrial free wall, so it could grow. And then this was put in to direct the inferior vena cava up through the old orifice of the superior vena cava into the base of the pulmonary artery. And the reason that this came about was some work that Dr. de Laval had done in vitro, showing that if you had a big bulbous area in the pathway, that it was more or less like introducing a 50 or 60% stenosis. You lost that much energy due to eddy currents and other flow disturbances in this. Whereas if you had a much more streamlined, smaller pathway, that you paid a much lower price in energy loss going through here. So this was the basis for this type of operation. And this is a lateral tunnel type of Fontan. Here's the anterior wall of the heart. This was a patient with hypoplastic left heart syndrome. This is a big hypertrophied right ventricle. You can see the tricuspid valve in here against the septum, typical of a tricuspid valve, right ventricle, and the pulmonary outflow above, which is the neo-aortic valve. And back here is this tiny little left ventricular chamber right here. That's all there is of the left ventricle in this heart. So the right ventricle, of course, is the systemic ventricle. Very hypertrophied ventricle, these left ventricles. So now if we look over here in the right atrium, you can see this sort of half of a Gore-Tex conduit here that's been sewn in to create the pathway. And so it's running like this. The inferior vena cava enters the floor of this pathway over here. There's inferior vena cava coming in. And then if we follow it up, it makes a little tube here with atrial free wall here on the right and posterior aspect. And this is the junction with the right pulmonary artery. You can see this is the right pulmonary artery here, going off to the right lung. The superior cavopulmonary anastomosis is here, going down through the superior vena cava into the right pulmonary artery there and down into below. So this is the typical lateral tunnel appearance. And then in 1990, Dr. Carlo Marcelletti at Bambino Gesù Hospital in Rome introduced the idea of an extracardiac conduit Fontan. The advantages of this were that it didn't involve a lot of atrial surgery. There was not a lot of suture lines in the atrium. The hope was that this would be less thrombogenic, less arrhythmogenic, and it was easier to perform. You could do this off bypass. You could sew the tube into the side of the cava, and then after you sewed it into the PA, obstruct the cava, and then you could do this without cardiopulmonary bypass. And here's an example of an extracardiac conduit Fontan. Again, we're looking from the front. This was a patient with transposition and a smallish left ventricle and pulmonary stenosis. There's the little pulmonary root in the back. And here's a right ventricle again. You can see this tricuspid valve against the septum here, aorta coming from the right ventricle. There, aortic valve is here with a complete subaortic infundibulum or conus here under the aortic valve. And this is the extracardiac conduit here. You can see it's a tube of Gore-Tex that's just, we've opened it at postmortem, but it was a solid tube. And this is the inferior vena cava here, the anastomosis between the inferior vena cava and the inferior aspect of the tube. And this is the tube going up to the right pulmonary artery. There's the superior cava coming down from above into the pulmonary artery, and then this is the inferior vena cava being tunneled up through this tunnel. There's the right pulmonary artery there, and the proximal right pulmonary artery is on the other side going off to the left pulmonary artery. So there's the RPA, and then this is the proximal RPA on the other side, which would lead over to the bifurcation in the left pulmonary artery. So that was an extracardiac conduit Fontan. These are 3D reconstructions. This is a lateral tunnel. This is an extracardiac conduit. They're hard to tell apart by imaging. It's not obvious necessarily which is which just by imaging. So sometimes you have to look at the operative report to know what you're looking at. And then around the same time, 1990, Dr. Nancy Bridges at Children's, along with Dr. Aldo Castaneda, introduced the idea of fenestrating the Fontan, of putting a little hole, usually about 4 or 5 millimeters in diameter, in the patch, in the Gore-Tex. And the reason for that was to lower, at least temporarily, the systemic venous pressure, hoping to reduce serous drainage, edema, the kinds of things that we saw frequently and still do after Fontan operations, and also to improve filling of the left ventricle a little bit at the sacrifice of a little bit of cyanosis. So this particularly was useful for patients who were higher risk patients for Fontan. I don't know that anybody has ever shown a survival advantage of this, but in fact, this was a randomized controlled trial done at here in Texas, at Texas Southwestern, a few years ago, looking at the effects of fenestration. And this was a non-fenestrated group and fenestrated group, and you can see the days of drainage are substantially lower. The hospital stay was substantially lower, although mortality didn't seem to be any different. It was quite low, and it's quite low in everybody's experience now. You'd have to have a whole lot of patients to show much survival advantage in Fontan operations anymore. And then in the late 1990s, again, Marc de Laval began to use computational flow modeling as a way to try to plan the shape, try to plan the anatomy of the cavopulmonary anastomoses to optimize energy loss, or to minimize energy loss, optimize the flow through this. And Dr. Aji Yaganathan also at Georgia Tech has done a lot of work in this area. This was in vitro, but he has also done a lot of work, as have we, at Boston Children's, using MRs of patients, actual patients, and doing flow modeling with that based on their cath data to try to predict flow characteristics and to try to optimize the shape of the cavopulmonary anastomosis. So despite all of these changes and apparent improvements in the Fontan operation, if we look at the survival of the Fontan operation, well, these are data from Mayo Clinic. So a lot of their early data, I mean, this was in the 70s and early 80s when we had a lot of patients who were really poor candidates for Fontan operation being sent for Fontan because nobody knew how to take care of them. Before that, nobody anticipated that they were going to have a Fontan operation. And so they had lots of shunts, and they had their pulmonary arteries distorted, and they didn't have their left ventricular outflow tract or right ventricular outflow tract obstruction fixed. They had hypertrophied ventricles and all the rest. So there was a lot of loss early on. But even so, you can see that out here at 25 years, the survival is only about 50% in patients. Now, this is data. These are data from the Australia-New Zealand Fontan Registry, which is a very nice registry. They really are quite complete in their follow-up and patient ascertainment in the Australia and New Zealand area. And this starts about 1990. So this is long into the Fontan saga. And you can see that their outcomes are quite a bit better. If you look out here at 20 years, this is about probably 85% survival. The extracardiac conduit and lateral tunnel do better than atriopulmonary, which I think we all probably know that that's likely to be the case. But other groups, like the Leiden group from the Netherlands, has shown very similar to what the Mayo Clinic saw. Again, at 25, 30 years, it's about a 50% mortality rate. So I think what we can say about Fontan operations is that there's been really tremendous evolution of this over the years. The kinds of operations that are being done and were being done have changed, and this has largely been driven by the hemodynamics that were measured, and the flow characteristics that were being understood in this. It provides fair to good short to medium term palliation, 10, 15 years in patients, but really poor long-term palliation in these patients. And because of that, I think the idea and the interest in septation of particularly double inlet ventricles has really started to come back. And part of that was driven by this paper. This was from a Japanese group that did a number of these septation operations in the 80s, mostly from the late 70s to the beginning of the 90s. They did 22 patients. And if you look at their outcomes at 25 years, it doesn't look a lot different than a Fontan. And most of their loss was actually early. A lot of it was surgical. And that was done a long time ago. I think our technology today would probably make this look even a little bit better. And so if you look at, they catheterized all of these patients, the survivors, the 50% that were surviving, at an average of a median of 25 years after their septation. And the central venous pressure in these patients, look at this, the mean was 6. I mean, what Fontan patient has anything like that? Nobody. Their cardiac index was not too bad. Their ventricular functions, not too bad. So this looked kind of appealing. And in fact, at Children's, we have started a program of septation. Dr. Ramamani is the one who's really driving this. And when this publication came out last September, they had done 12. I think they're now up to about 15 patients that they've started staging toward a septation operation. And at that point, 5 had completed this. I think now this may be 6 or 7. And there were no deaths or cardiac transplants. 1 patient developed heart block. And all of these patients have filling pressures under 12, 8 or 10 for the most part, and have relatively normal cardiac outputs, and seem to be doing pretty well. 1 patient has modest ventricular dysfunction, an LV ejection fraction of about 50 or 52, but all the rest of them have really pretty normal ejection fractions, and their volumes are around normal, a little bit above, but around normal. So we're kind of encouraged. It's way too early to say anything about this at this point, but we're kind of encouraged, and it'll be interesting to see how this all turns out. So that's what I wanted to tell you today about Fontan operations, and I just wanted to tell you one other thing, and that is that we have put up a website in cooperation with the Department of Cardiovascular Surgery at Mie University in Japan. We had a couple of fellows from there in our lab, and we did high-resolution micro-CT scans of our waxed heart specimens and some other heart specimens. We now have a let me just get out of this and brought up the website. It's on Sketchfab. It's just sketchfab.com/heartmodels is the URL. That's freely available. Anybody can use it, look at it. For example, you just bring up the heart like this. It'll load the 3D model for you. It takes a few seconds to load it. And then you've got the model. You can play with it. You can go inside the heart if you want, look around, and they're all labeled. For example, if you click on a label, it'll show you what you're seeing, or click on that one, it'll show you what it is. So this is available for anybody who might be interested. So thank you very much.
Okay, well, thank you so much, Dr. Sanders, for a phenomenal review. We're going to open it for questions now.
That was really fantastic. So having the omniscience of retrospection, if you were to step back and take a look at the things over the last, I guess now 80 years in terms of single ventricle palliation, starting from unidirectional unilateral Glenn till now, if you had a time machine and you could nudge things just slightly in a better direction, how would you have liked to have seen things gone?
Yeah, I mean, you're presuming, I guess, that technology of today would be available, but of course it wasn't. And that was what was driving a lot of what was being done, right? I mean, it was what you could do. I mean, that was one of the things that drove Carlin to do the cable pulmonary anastomosis, was that he wasn't very good at doing Blalock shunts because it was hard to operate on little kids' subclavian arteries. You know, they just didn't have the technology to do that. It was easier to use a bigger vessel like the superior vena cava to be able to do it. So I don't know what would change or how you would change things. You know, I guess one thing that one might do is not quite back that far, but in the 70s and early 80s, is to pay more attention to the idea of septation, because I think this may be a better way to go. And I think one of the reasons that I think it didn't do as well as it did was because most of the patients were much older. I think you have to do this in really very young patients, really in the first couple of years of life. And the reason for that is then you put a small patch in, and then the myocardium sort of invaginates around that patch, and you get much more muscle wall, whereas if you do it in a nearly adult-sized heart, the patch just stays inert. Whereas this way you can get muscle growing in around this patch and being active. And we've seen that in the one patient that was started about 4 years ago, that there's been a fair amount of growth, and in fact, the patch, of course, obviously stays the same size. So something has to increase there, and it has to be the patient's native muscle. So I think that may be something that's going to be interesting. Again, way too early to make any kind of statements. But I think that would be what I would suggest, was that not enough attention was paid to the possibility of septating these ventricles. Hi.
Hi, good morning. Thank you for that, and also thank you for sharing your website for those like myself who are 3D challenged in thinking. It's amazing to have access to those. But my question, obviously septation is a very appealing and striking thought, but not all patients obviously will be candidates for septation. Right. And I think we've seen kind of a little, in my time, of seeing the push of Fontan earlier, and now maybe we're really, thought maybe we went too far. So what are your thoughts of the timing of Fontan, now leaving them with the bidirectional Glenn for a longer period of time before we move forward?
Yeah, I mean, that's a good question. I don't think we have the data to tell you about that. I mean, I think one of the issues, of course, with bidirectional Glenn is that as patients grow, less and less blood is coming back, or proportionately of their cardiac output is coming back from the SVC. You know, it starts out almost 50-50 in little babies, and then drops down to maybe a quarter by the time you're, you know, you're an older child or teenager. And so I think patients tend to get blue with this is part of the problem. But if you only leave it for a few years, I mean, what are we doing? Are we just postponing the eventual decline of the Fontan? Because, I mean, what's happening here? Well, several things, really. I mean, probably mostly the ventricle is starting to deteriorate because of chronic volume unloading. We know this isn't good for your ventricle. It makes your ventricle get stiff over time. Everybody, or a lot of people, have shown that this happens. And, you know, you get other problems from having your systemic venous pressure be 18 for most of your life. That's not the way we evolved. Our livers don't like it. Our bowels don't like it. You know, it's just, it's a problem. So I think that what you're doing when you do that with a bidirectional Glenn for a few years is just sort of postponing the inevitable. I think, you know, what we have to think more toward is either some kind of chronic mechanical support or some way to grow a ventricle in some fashion. And we just don't have the biomaterials for chronic mechanical support. And we've, you know, we could do it as far as probably as far as making a pump, but the problem is making a surface that doesn't cause blood clots.
Dr. Sanders, thank you. Fabulous presentation, and really, you know, it's amazing to see the robust history from the surgery and the lessons and probably the warnings. So that's really my question is transitioning to the group of acquired adult right-sided pathologies, which is certainly having a resurgence of interest at the moment, and there's lots of transcatheter innovation for edge-to-edge repair of the tricuspid valve, and transcatheter total valve implantation, typically in the tricuspid space, and at Houston Methodist, as recently as yesterday, our first cable transcatheter heart valve implantation for somebody who could not have a transcatheter tricuspid valve. So there's a huge interest in, and you know, there's a lot of high-fiving and success perceived just by getting a device in.
Sure.
But not a lot, I would say not a robust knowledge base on what happens next.
Yeah.
What happens in the next 30 days, 1 year,
Yeah.
and with, you know, your era of decades of experience and what happens to these patients. Just wondering if you could share some wisdom or some warnings for all of this messing in the right heart that we're getting into.
Well, you know, we know that one, bioprosthetic valves tend to, at least in children, tend to do better in the right side than they do in the left side. They tend to last a bit longer. I guess because they're under lower pressure. I assume that's what it is. I don't know that's what it is. But they, thrombosis definitely occurs. These valves get coated with fibrin. Even if you anticoagulate them for a while, probably unless you anticoagulate them permanently, they're going to get coated with fibrin. And what happens to the fibrin? It forms fibrous tissue. And so the leaflets get stiff, they get thick and they get stiff. And this happens, at least in children, over a few years. You know, we get bioprosthetic valves in the right side to last 10, 12 years, occasionally 15 years. But most of the time it's closer to 10 or 12. And a lot of the way they fail, it depends on bovine pericardial valves tend to get this covering of fibrous material. Porcine valves tend to calcify. And so there are a lot of ways that they fail. I mean, that's all I can tell you is we don't have a valve that's going to last a lifetime. They don't exist at this point. I wish they would. You know, Dr. Del Nido and his group is working on an expandable, sort of like a Melody, but actually I hope it's going to be better than the Melody, that you can put in quite small and really expand it serially over years as the child grows, and have enough height of the valve so that as you expand it, you still have adequate coaptation. So I don't know. I don't know what's going to come of this, but it'll be interesting to see, just like it's been very interesting to watch what's happened with the Fontan operation over years.
Phenomenal talk.
Thank you.
And I think to add, one of my colleagues texted us in between your talk saying you're the most tech-savvy professor of medicine he's ever seen.
I'm sorry?
You're the most tech-savvy
Oh.
professor of medicine for you to time your videos to how you talk. So I think we need to probably learn a lot from that also. A question, probably extension of what Steve asked also, learning a lot on adult RV failure and impact of the liver from the RV.
Yes.
And maybe even in the Fontans, because in the case of transplants, we tend up doing a lot of heart livers.
Heart liver, yes, sure.
And I've always wondered, and is there any insight, is there an anatomical attribute that makes some individuals have more backup into your IVC and the inferior circulation compared to the pressure being distributed? Because even in regular RV failure, there are some patients who are end up with like just the other day we had an obese individual with an RA of 40. Almost sounds not compatible with life.
Yeah.
But the LFTs are not
Elevated particularly?
that much. So I've always wondered if there's an anatomical attribute and you look at all the Fontans on the angle or whichever it comes to.
Yeah. I mean, it could be, although, I mean, I'm not impressed that the IVC pressure is ever much lower. I mean, it's pretty uncommon to have IVC obstruction, in my experience in this. SVC obstruction sometimes, but IVC obstruction is less common. So I think most of the time the liver in these Fontan patients is exposed to similar pressure. I strongly suspect that there are probably genetic propensities to developing, triad fibrosis in the liver and other things like that. Patients may be more prone, their fibrotic pathways may be more active, and that may be part of the difference. Whether it's really anatomic to the IVC, could be, but I suspect not.
We have some questions from our online audience. First, we have greetings from many countries: Argentina, Brazil, Mexico, Colombia, Barcelona, Spain. I wrote them down so I don't miss them. Bologna and Verona in Italy. So this just goes to say how much global relevance this topic has how all of us are trying to learn how to help these patients. We have Dr. Sogby, who is our chief, says thank you for a clear and comprehensive review, Dr. Sanders. Just to put it all together for our adult cardiology audience and our fellows, in 2023, what is the ideal course of action for a patient born with a single ventricle? What's the pathway you envision that may have the best outcomes, including the type of Fontan?
Well, I think we don't know that at this point because I think we don't have the data from septation. I'm getting more and more sold on the idea of trying septation. I mean, we already have the data in Fontans, and we know it's not very good long term, no matter what you do. So and this is obviously only applicable to patients, really with 2 AV valves and a sizable enough ventricle to be able to support it, and without a lot of other. Although we are using this in heterotaxy syndromes, they're doing some heterotaxies with common AV valve and dividing the AV valve and doing it that way. I'm less sanguine about those than about ones with 2 reasonable atrioventricular valves, double inlet lefts, the rare double inlet right. But that leaves out patients like with hypoplastic left heart syndrome, patients with tricuspid atresia, patients with mitral atresia, double outlet right ventricle, some of these kind of things where there aren't 2 AV valves. So there, I don't see that we have much choice at this point other than progressing them down the pathway of a Fontan. And I think the keys for that are simply trying to do the best we can to manage the pulmonary circulation so that it's in the best condition for Fontan, that we manage their ventricles so that they don't become hypertrophied or terribly volume loaded, and try and make them the best candidates that we can, like we've been doing for years, but sometimes it works better than others. And in the double inlets, I think it's worth, at least in a couple of places, trying the septation, particularly from a pretty young age, and getting patches in early so that you can get some ingrowth of myocardium and invagination of myocardium to try to make a more muscular interventricular septum. Other than that, I don't think we have any good answers for some of these patients. I mean, it's sort of like, when in the early 1970s, when McDonald Dick and Dr. Natus published this paper on 100 patients with tricuspid atresia, and most of them were dead before they were 30. We're doing a lot better than that. In fact, most of them were dead before they were 20. But we're doing a lot better than that, but we still have a long way to go.
Thank you, Dr. Sanderson. One last question. As an adult cardiologist and transplant cardiologist in the receiving end of these patients, we always face the dilemma of when to trigger transplant evaluation for these patients. So broadly, we have a group of patients with heart and liver dysfunction who go the heart and liver transplantation pathway. Then we have patients with fibrosis of the liver, and the question is there: do we trigger a heart transplantation there before the liver gets affected, or we wait? And I know that the data here is very limited, but from all the lessons you have learned through this journey, exciting journey of the single ventricle palliation, what's your gut feeling about it?
One thing is, the liver pathology is certainly real, but I've always been surprised at how ugly livers could look and have really fairly mild elevations of LFTs and still make plenty of albumin and clotting factors. So I think sometimes we may overestimate how bad the liver is, both from imaging and from mild elevation of some of the things. So, I mean, you certainly would like to avoid a liver transplant. So, listing patients for heart transplant appropriately before their livers are really gone. But I guess what I'm saying is that I would think that some patients will do okay with just a heart, even if they have some abnormalities, particularly of liver imaging. My sense is that the imaging somehow overestimates how bad things are and underestimates the functional ability of livers.
Wonderful. Thank you.
I don't know how else to answer it. Honestly.
Yes, no, that's great. That's great. It's a tricky question.
Yeah, it is.
Well, thank you everybody for attending, and Dr. Sanders
Thank
again,
you.
thank you so much.